Hello, everybody. Welcome to Fighting for the Soul of General Practice, an In Conversation podcast mini-series where we explore the complex realities of modern general practice. In today's episode, I'm joined by my regular co-hosts, authors and general practitioners, Rupal, Shah and Foell. But we're also joined today by a very special guest, Dr. David Armstrong. David, thank you for joining us. Welcome to the show. It's wonderful to have you on. Can I just start by asking you who you are? Just tell us a little brief introduction about yourself. It'd be great to know why you're here today.
Yes, well, I was invited by Jens, who's an old colleague of mine. So my name's David Armstrong. I'm Professor of Medicine and Sociology at King's College London. I've got a slightly strange background because I did medicine, then sociology, hence my twin disciplines in my title. And I have kept going with those two, riding those two horses. So partly I do medical epidemiological research and partly I do sociological research. My medical side is, I did general practice way back, long time ago, and also public health medicine. So that's my main areas in the medical field. And then sociology, I'm mainly interested, I suppose, in the sociology of medical knowledge.
Thank you very much. That is a really interesting combo. I've got a bit of a weird question I like to ask people from time to time. Can you remember, was there a distinct moment when you decided you wanted to work in the medical profession? Or was it a calling, or was it because it was something that you knew your mum and dad might want you to do? What drew you into the profession?
Oh, I have to ask my analyst.
Yeah, right.
I don't know. I vaguely recall, 15 or 16. I quite liked animals, and I thought about being a vet. And I was told getting to veterinary school was very, very difficult. So, all right, I'll be a doctor.
You know what? I think you're the second person who's given that answer during this podcast series. So it's good to know. Well, thank you very much for sharing that, and thank you for the introduction. So today we're going to ask a few questions around, I guess, power, risk, discipline, and sort of where are we now? What happens when general practice is pulled between serving individual patients and meeting the demands of a system shaped by targets, risk management, population control, and other topics around polypharmacy and various other bits and pieces. But I wanted to start by focusing a little bit on power in practice. And David, maybe you could answer this one. Who for you holds power in general practice today, and how has that maybe changed since you were actually a practicing doctor yourself?
Yeah, well, things have changed in general practice, and I share a lot of our colleagues' views of general practice, but in a way, it's a nostalgia of a lost world. And it was a nice world, but I think it has gone, and I'm not sure we can get it back. So most of my interest is sort of seeing where we're going rather than trying to sort of return things. On the notion of power, I take my sort of position from Michel Foucault, who in a book called Discipline and Punish, he described two forms of power. The first form of power was sovereignty, where all power was vested in the king or the king-like figures, so the king's magistrates and the king's officers and everyone to whom the king had given power. And power was something that the king held, that he displayed to everybody, so everybody could look and see the majesty of the king, processions and ceremonies and everything. So everything was like that. And Foucault has said that we failed to cut off the head of the king, so we still think in those terms. We say, does the GP hold power over the patient? Oh no, maybe the patient these days holds power over the doctor. But power, there's the other form of power which came into being about 200 years ago at the end of the 18th century, which he called disciplinary power. And this power was affected by what he called an inversion of visibility. So in sovereign power, you had to look at the king from a distance and think, wow, he holds all the power, isn't it wonderful? Whereas there was an inversion, and suddenly people started to look at the patient, at the individual, at the citizen. And he describes this in a prison system where before, when punishment used to be public hangings and whatever, beheadings and so on. And then it moved to putting people in prison where you just simply observed them. So Foucault said this is a disciplinary system where the patient, this criminal, the individual is held by surveillance. And if I think back to my school class, I was constantly observed. I was tested. I was watched all the time. I think about university, that's exactly the same. Then you get into medicine, and you're always being watched. You're always being surveyed. Now, that surveillance, that watching, sort of objectifies you, but at the same time creates you. So Foucault's argument is disciplinary power is not negative like the sovereign power, but it's productive. So what we have today, our identities, who we are, the way we think, I suppose what we're talking about today comes from disciplinary power. We have been constructed by disciplinary power. And so when you say who holds power in the doctor-patient relationship, well, in a way, the power comes from the stethoscope. Because the stethoscope enables you to listen, that is a form of power. Because the doctor says to the patient, tell me your troubles, that is a form of power. But it's not a power that the doctor is exercising over the patient, but rather constructing the patient. And the worst patients are those who say, how do you feel? Oh, I don't know what you mean, doctor. I thought I'd come with my sore throat. What you want them to do is start confessing. They've got to start revealing, either visually or orally, about what's going on. Sorry, I've spoken a bit long there, but
no, that's fantastic, David. I really like that that analogy and your sort of Foucauldian reading there. I'm going to bring in my colleagues here, though. Jens, Rube, how do you feel about that? How do you feel about that take on who holds the power? You're both still working in the profession. Rube, let's go to you.
Oh, that really chimed about wanting patients to confess. I can think of lots of examples. But when someone comes in and I can see that they've had a lot of, complex social issues, for example, in the past, and I'm meeting them and I want them to confess, I ask leading questions. I look very sympathetic. I want them to confess because I'm kind of trained to do that. And I have been thinking a lot about whether the ethics of that, should I force the story or try to force it? Why?
To give them an identity. To make them subjects, subjective, reflexive. Yeah, so reflexivity doesn't come, we're not born with reflexivity. It comes through this, exactly what you described. So somebody says to you, how do you think? How do you feel? What are your thoughts? Okay, great. I'll start to reveal all these things. And in the process, I will become this thing called reflexive, subjective, and so on. So you're very productive. It's a very productive technique you're using there, Rube. So don't knock it.
I think I'm a proper agent of social control, but I'm also controlled. So I need to know the system. I get controlled, so I have to reflect on cases. I have to reflect on misses, near misses, reflect on the complaint letters. I take this every year to the appraisal. I have to engage in appraisal to keep my license. So I have to learn to be a reflective practitioner, but not too reflective, because then that would raise suspicions. So I can. So with the first doctor I worked for didn't really know how to reflect. So I was from a newer generation, more touchy-feely. So he wanted to have me as a ghostwriter for his appraisal, because he knew there are people who make his life difficult. He came from a more sovereign, I'm the boss, it's my practice background. I didn't do that, but I found it very interesting how these power relationships, who disciplines the disciplinarian, etc., who controls the controller work. I do that also with the patients, and patients come to see me and they feel ashamed and embarrassed about their lifestyle and their sins. But I do the same when I go to my GP, because I know I'm not a flawless person, and I'm allowed to be enough fallible, but not too much. And people write that in the appraisals. Usually they score their health level between 7 and 8 out of 10. 10 out of 10 is very suspicious. 4 out of 10 also raises questions. And everybody looks after themselves. They're eating well, they're exercising, they're good doctors, good citizens.
I was at the doctor's yesterday, and I did find myself listing all the ways that I've been a good patient. So I think that does make some sense. You as doctors, though, you're not only serving the patients these days, you're certainly serving the system as well, if that's fair to say. So do you feel that targets and systems, they affect your sense of autonomy and of power?
I think it's interesting. I don't think we conceptualize it like that. I mean, of course they do, it does, and there's no question, but we're so used to being agents of the state. I think we've stopped questioning it. You know, QOF has been around for 20 years, something like that. And I think it's become part of our professional identity. So it's quite hard to question what we would do differently. And I really think we should ask those questions, but I'm not sure that we do. I think we accept way too much.
David, any thoughts on that?
No thoughts on QOF. It's a way of making extra money, but it's the main one, I guess.
I'm not sure. I think all is really, really bad, and it averages everybody and makes everybody a population average, and then you have to treat them as part of a population, and you have to treat them with equity as a parcel and not as a puppet. And that's easy to rebel against that. But on the other hand, if there's a medicine of crackery or favoritism or fads for the rich ones, then it's also not right. There's a kind of socialist agenda as a funny socialist and at the same time capitalist agenda in the medicine we do here. If I compare it to medicine in Germany or medicine in the private sector, I don't know whether it is so desirable, but there's something I'm longing and I'm missing, and I'm not getting it at the moment.
But I think QOF's a way of getting GPs to behave themselves. In the 1970s, 1980s, there was some data started to emerge that clinicians all did different things. So faced with exactly the same patient, there's some classic work, I think, done on tonsils, need for a tonsillectomy. And every doctor had a different view. Have you got tonsillitis? Have you not got tonsillitis? Do you need surgery? Should you get surgery? And so on. So there's tremendous variability. And they looked at every sort of clinical practice there was, and there was variability. That can't be good. So the argument is that can't be good because if some patients are getting operated on, some are not, who's benefiting and who's disbenefiting there? And that's why we start to move into the risk probability data when we have data which tells us that you shouldn't be operating on tonsils. I believe some trials tell us that we shouldn't be operating on all tonsils as we used to. And therefore, we tell doctors that they shouldn't be. And sometimes doctors don't listen. And so we've got to bribe them. So yeah, I think that's the background behind QOF, is to try and bribe you guys to behave yourselves.
Ru, any thoughts on that?
Yeah, no, I think there is something in that. And obviously we've talked before about the benefits of standardization and how nobody wants to go back to a time when people, loads of kids had unnecessary tonsillectomies. But I think somewhere along the line, we've lost kind of like an overall sense of why we're doing what we're doing. And I think we tend to buy into this narrative that we're busy reducing risk left, right, and center without thinking how much by and what are we not doing by doing all this recalling work and measurements and stuff. What aren't we doing, and how much benefit is there anyway in particular kind of preventative measures?
Yeah, I think the surveillance machinery coupled with lots of data gathering, coupled with a focus on medication and drugs has got a life on its own. So if you asked in the beginning who has the power, I don't think it's a particular group or the pharma industry or the government or kind of large organization. I don't think that's the case. It's more autopoietic, moving by itself, and possibly not being slowed down or questioned enough to find what are we actually doing here and how are we doing that.
Yeah, there is some sociological work on the social life of methods, which I've sort of used in the past. So methods themselves have a social life. They have an autonomy, that the sort of autopilot you're talking about. They have an autonomy. So that risk probability method spreads and starts to infect everything it touches. So you guys now, I absolutely agree with Ru that you're now totally risk averse. So if you've got that's the effect size of antihypertensives is of the order of 1 in 500 patients will benefit in any year. It's minuscule, but most of the interventions that medicine does give are very, very small. But we've become so risk averse because if one patient gets a stroke who you haven't given antihypertensives for, somebody's going to start complaining and you guys are in trouble. It'll get in the Daily Mail and suddenly the world changes.
I wanted to ask a few more questions around this idea of risk, and I know that's something that you've spoken about before, Ru. And I've read elsewhere that we are now sort of treating risk rather than illness. Is that a fair statement?
Absolutely. We're completely preoccupied by risk. And even if you take a very scientific approach, we don't have a good conception of risk because it's all, as everyone knows, we talk about relative risk reductions. We don't talk about absolute risk reductions, numbers needed to treat, numbers needed to harm. So I think that for most clinicians, we don't have a good grounding, like a good feeling about what kind of risk we're talking about. And so it's definitely overinflated. We suggest things really believing that it's very, very important and, definitely overstating that.
I think it's the emotional impact of risk. Something could happen and there's something you can do about it. And I'm sure that people think less about that if they put a safety belt on in the car or with other aspects of minimizing risk than if it comes off with the risk of health and the risk of life when you go to the doctor and you think about what about my PSA, what about other threats that are there for my life. It is completely irrational in the name of science. That is very, very difficult to navigate, I think.
And well, if we're talking about risk and power, and Jens, you refer to yourself sometimes as a street level bureaucrat when it comes to the medical profession. And does this power and risk relationship change the role of the doctor in moving forward as well? Like we're talking about the future rather than nostalgia. Has that changed the role of the general practitioner?
I think it does. I'm answering quickly because I often have to decide, am I on, if a certain condition is favored by QOF and I benefit as from the practice, do I favor putting people on a register knowing it's not good, or do I favor their right of autonomy even if I think it comes at a price for practice income? That is definitely a conflict, a street level bureaucrat conflict where I have to favorize conceptualizing the patient as parcel or puppet.
Yeah, no, I think it stops us from taking a kind of person-centered view within an interaction and kind of following what one would call a sort of moral sense of the conversation that should be happening. If someone comes in, they're in their mid-80s, they've got heart failure, then actually, if you were allowed to listen to your heart, I don't know how you frame that, but you probably want to have a conversation about mortality, about what they want, all of that. But what you might do, because it's so much easier and it's so much in the forefront of our minds, is instead say, well, I notice you're not on dapagliflozin. Let's think about that. And that's much quicker. It ticks some boxes, and then they can go and have some monitoring for that. But I think it generates a lot of waste. And I think we've spoken before, haven't we, about how that kind of practice of medicine, the effects that it has.
David?
Yeah, I think medicine has changed irreversibly in all sorts of ways. You might see it as a good thing or a bad thing, depending on your perspective. But in 1948, when the NHS came into being, I think 90% of all GPs were single-handed. And that meant that they were on duty 365 days a year with 24 hours, and they had to find a locum if ever they wanted to go on holiday. I mean, it was a struggle, and they managed because that was their life. It was a vocation. And I suppose when I went to medical school, I caught the tail end of that. So it was a vocation. If I was on a plane and somebody was ill, or I was in a hotel and somebody was ill, then I was a doctor. So I could be called upon to help. I recently, a few years ago, I was on some committee at the Royal College of Physicians looking at the future of the profession, and there were some junior doctors there, and they were adamant that they were on a 9 to 5 shift. They stopped at 5 o'clock, they went home, and they were not a doctor any longer. They were a husband, a father, or a mother, or whatever. They took on a different role. In the same way, if they were on a plane and there was somebody says, "Is there a doctor on the plane?" So they wouldn't put their hand up. Even if there was somebody, in the corner who was ill, they wouldn't put, they were off. But it's right, if you go to a hotel and there's a leak, you don't say, "Is there any guest who's a plumber who can come and fix this leak?" You get somebody else in. So the expectation is that once you're off, you're off. So first of all, the medical role becomes very circumscribed. The other thing that amazes me about these young doctors is how protocol driven they are. They don't handle uncertainty, they run the protocol. So they go through the tick boxing exercise, and we're creating these people, we're training these people like that. And that's this risk probability method, if you like, which has taken over. So I think the doctor of today, who's being qualified, who's trained, who's what their expectations are, is very, very different from what they were, 50, 70 years ago.
Thank you, David. Ru, please respond to that.
I suppose harking back to our conversation at the beginning, it's why I have these reservations about entering people's life worlds now, because I think it's one thing asking permission to do that if it's, if I'm going to be around all the time and, I'm going to offer them some kind of relationship ongoing. If I'm not, then I think maybe it's just none of my business and I shouldn't go there unless they want me to, and that it's kind of clear that they want me to. So I'm not sure.
I notice a discrepancy. We had recently a conversation with Roger Kneebone about medicine as craftsmanship. And I thought, well, we are exactly at this juncture in time. On one hand, we are preparing people for a long, long time to develop the identity of a craftsperson. On the other hand, we have industrialized healthcare, which relies on data, which relies on algorithms. If you are in out-of-hour medicine, in unscheduled care, the trick is always to consult the algorithm and you are safe. And if you step across the boundaries, you have to ask in the hierarchy whether you can step outside. And it's extremely rule-based and often ridiculous. And people know it's not in the patient's interest, but stepping outside and risking autonomy or breaking the mold, that puts your professional integrity at risk. That I find that sad.
I wanted to ask a question about if you could intervene and reshape the system in any way, David. Are there any things that you would change based on your thoughts you've shared with us today?
No, I think it was Marx said that Hegel studied the world. The problem was to change it, and I'm a Hegelian. I think the problem is to study the world. So I don't have a formula for where I want to go, like old Karl Marx.
That's a cracking answer. Well, I want to bring in Jens and Ru here as well, because I know that you probably have some questions for David, Jens. And anything you want to ask while we have our guest on today?
I wanted David to analyze the situation a little bit more, because I feel I'm deluded. I'm tragically deluded, like Don Quixote fighting the windmills of bureaucracy, thinking there must be a way of good medicine where people care and have common sense and have intensive relationships, where maybe generalists are the guide on the side to find out when is medicine good and when is medicine not good. But I fear that my trainee is right in thinking, no, you're a man from the past, you're deluded. Maybe we'll just have to see what kind of methods will emerge right now. If it's like fashion and every fashion has a social life, then it's fine. And I should calm down a little bit.
I think it's a bit more fundamental than fashion. I think there are fundamental epistemological changes in the nature of knowledge that doctors now use, in the way they practice, and as I say, in their even their identities. They are different sorts of people, and so they're closer in some ways to, I don't know, to an electrician or something, who must follow the rules. You know, you don't want to join the wrong wires, and you got to follow the rules. And if you follow the rules and you've got a certain hours you work and you get reasonably well paid, so that's the way medicine's going. Which I can exactly see where you're coming from, Jens, because I've got a certain nostalgia. Oh, you know, there was something nice. I used to do a lot of training with GPs and things, and we used to do a lot of reflection and role plays and fish bowls, and I mean, it was a wonderful atmosphere, and I really felt that we were changing the world. But in retrospect, I think we've moved on, haven't we? I think we become the dinosaurs who are left to reflect, to nostalgically reflect on the past.
I disagree, and
good.
I disagree because I see in my daily practice what I need most, and people come into my closet. People tell stories that don't immediately make sense and get rendered to diagnosis and procedures. There is this role of a social pastoral carer that GPs still have. Why? I don't know, but people come every day and cry and tell me things. There is a need for this kind of pastoral care. There is this need when it comes to pain, suffering, death, and that's not captured in putting everything into categories. There is an absolute need.
I agree. I agree with Jens. I think there's so many patients who still seem to want us in that role, and lots of colleagues who are feeling the same as Jens and myself. So I don't think it's hopeless. And I think that AI could make a big difference. You know, we talked about that in a previous podcast. It could make a huge difference for the better in terms of allowing us to be interpreters, that kind of function, or it could make it worse.
In a funny way, I don't think that people think I go to the GP and I want to cry and talk about emotions. I really don't think that. I think it happens, and it is a kind of space where it's allowed to happen, but nobody comes with the intention. So this is what I want to have dealt with. I need to get this off my chest, and so that's not the case. And I'm not inviting people to regularly cleanse to regulate their emotions by coming to the GP and crying. Then it would not work.
No, that's true.
But there's some element in the packet of Kleenex as well as the stethoscope, it sounds like, as well, though.
Yeah, absolutely. You need both.
David, did you want to respond to any of the points there that these made?
No. I can see. I mean, can I ask you a question? Is it that some patients want to? They might not want to cry when they come in, but they're used to. They take an opportunity to cry, to confess, to reveal something emotional about themselves. Is this older patients or the very younger patients, or is it right across the board?
I would say right across the board, and I wouldn't gender, age, class stereotype in it. It's honestly across the board, and maybe there's a difference that some practitioners use more tissues and have more and invite this to happen than others. But I think for the emotional hygiene of the population, GPs are very important.
Do you think this has changed at all? We mentioned earlier with the role of the patient in this dynamic and relationship now, and that a lot of patients, I found myself doing it yesterday, turn up with their preconceived notions from Google and their own research of what's wrong with them. Do you think that patients are more informed, and then that changes the role with the doctor in that they want that emotional support? Because they feel like they're coming in with some information, and there's more space to have a different kind of relationship with you, Ru?
Absolutely. You know, and sorry to mention AI again, but I think it's not just Google now, is it? It's conversations with whichever AI you're using, and so I think the knowledge gap is reducing. And so if you can't hold yourself up anymore as an expert in the way that you could 10 or 15 years ago, even, so I think that dynamic has changed, and probably the most successful GPs are the ones who are able to kind of act as interpreters to sort of have a kind of equal conversation with someone to help them navigate through healthcare.
I would just add, though, I think that with all of these tools like LLMs and AI and the impacts of technology, for me as a patient, it's almost like I want to trust the experts more. And although I want to utilize these tools and I want them to, technology to be embraced by the medical profession, I almost put more stock in the word of an expert than ever before. But that might be showing my age and various other things too. But I almost feel like we need these experts more than ever to help interpret, like, the tools and information that we have at our disposal as the general population. Which we didn't have previously, but almost this Pandora's box, right? And it opens up. You haven't had any expert training, and all of a sudden you're trying to interpret information that's being delivered to you by one of these tools.
But I don't think the GP can often interpret it either, because it's a risk, it's a probability. So if you take a patient, they want to take the contraceptive pill, what is the risk of taking the contraceptive pill? Well, it's got there is a risk, but it's very, very, very small. But there's a risk if you don't take it, you'll get pregnant, and you might get a slightly higher risk because you're pregnant. So all of these things need a value judgment. You've got to. It's a bit like nuchal folds in scanning for the babies. The nuchal fold will tell you what's the risk of a spina bifida, and the risk might be 1 in 200. Do you want to terminate the pregnancy or not? 1 in 200, 1 in 50, 1 in 20. At what point? And it's not for the doctor to say what you should do. All the doctor can do is somehow give you these probability estimates, and sometimes there's a benefit and sometimes there's a harm, and sort of say, well, what do you want to do? So I don't think the doctor has got any greater wisdom. They might be able to frame it differently, perhaps with a decision aid or something to help you make a decision. But ultimately, with all these risk probabilities, the patient's got to make their own decisions. They can say, "Oh, well, what would you do, doctor?" But some doctors, I'm sure, would tell them. Others would say, "No, I won't tell you. It's up to you."
It's extremely difficult to understand and to teach. I think very, very few people, maybe accountants or actuaries or statisticians, can actually understand what it means. Even if it comes to my risk is 1 in 20, one person would say, "Oh, this is awful. I will never ever do that." And the next one is a extreme mountaineer climber and will say, "Well, that's fine. I go for it."
Yeah. So it's up to the patient. It depends how risk averse they are and how willing they are to take risks. I mean, some people buy lottery tickets, don't they? There's some weird people out there.
David, I just wonder what your thoughts are on risk being such a powerful arbiter of this space of uncertainty. I think we're preoccupied with risk. Patients are preoccupied with risk because it's everywhere. Get your PSA checked. If you've had a cough for more than 3 weeks, you might have lung cancer. If you've got a bit of blood in your poo, go and see your GP immediately. We're bombarded with these messages. So it's kind of very deep into our way of thinking, and who is responsible for that is a different argument. But this is where we are now, and I just wondered if you had any thoughts or advice for us.
Well, in the past, I guess GPs or doctors in general used to handle uncertainty. There's a lot of uncertainty in clinical practice, and then from about 50 years ago, in that paper on risk probabilities, described how that uncertainty got quantified. So we now live in a world where uncertainty can be quantified. I can give an estimate for any uncertainty you tell me. I'll give an estimate. I might be wrong, but I can give confidence intervals and sensitivity analyses and so on to actually express what that risk is. And then you've got to handle it. But the problem with a risk, it's based on a population and it's got to apply to a patient. So you've got a 1 in 200 chance of having a stroke if you don't take this medicine. Well, that's 199 ways of avoiding it. How do you present the risk to the patient, and how does the patient interpret it? It's not easy for either party now. We're in a world of sort of trading risks, and I can't see a way out of it. I can't see some sort of magic way that somehow the calculation will disappear. We can't, forget calculations, maths, probabilities. We can't. It's already taken us over.
And in a way, I mean, you'd think the biggest risks are, of course, from social determinants and a lack of connection and etc. And I just wonder if branches like lifestyle medicine are somehow kind of taking that on. The reason they've come into existence is because we're also preoccupied with kind of almost the wrong risks instead of looking at the bigger picture. And so perhaps that's why they've had to come into existence. I don't know.
I wonder whether the problem is that the risks, the numbers are in the context of life, death, health. And it's bizarre that I, as a GP and doctor, say, well, health is completely inflated, the concept. Why do you not think about risk in all other activities? It is kind of, it's not right. It's too important, but I'm benefiting from this importance. And so, yes, I'm a hypocrite.
We've spoken a bit about power and we've spoken a bit about risk, and I did want to just sort of broach the subject of the GP as sort of carer and disciplinarian. And do you find yourselves as general practitioners, and you, David, when you were a GP as well, do you find yourselves sort of disciplining patients, is that intentional, or is that part of the system? Do you have any thoughts on that?
I think we do at a population level. If people don't come in for their reviews, then we'll do things like, we'll text them a lot of times, we might phone them, we'll reduce the quantity of medication to make life more inconvenient for them. So I think on that level, we certainly do. There's a temptation to do it in individual consultations. I think, I don't think that I do it personally, but there's certainly a kind of temptation to say, well, why is your diabetes so bad, or your blood pressure? Why aren't, honestly, like, you're just a very bad patient. You should be, why won't you take this extra medication? So I think we are definitely disciplinarians.
So discipline is a product of population management in a sense.
Yeah, absolutely. For lifestyle management, obligatory with recommended quantities of exercises ratified by a Royal College, with different diets. Everything is regulated. And my activity as agent of social control is also to justify work absence, to have access, to enable access to benefits, to all these processes of social administration, which are normative. And I hope I get paid for that if somebody cannot go on their flight, that they pay £30 and so forth. That's part of our business model. And if it comes to mental health, then it's part of our raison d'etre. Psychiatrists are intrinsically linked to social control, and we GPs in the realm of mental health just think about sick note legislation. We are in it right from the start.
Can I comment on you being a disciplinarian? Because there are two ways, a bit back to the beginning, talking at the start of this podcast. There is two ways of handling somebody who's not behaving. Let's see, they're smoking, or they're not getting exercise, or whatever it is. And one way is to tell them off, is to sort of say, you shouldn't be doing that. Do you realize it's harmful, and so on? And that is disciplinarian. The other one is to get them to confess. And that is non-direct, let's call it non-directive counselling, it used to be called. And it's probably far more effective in actually getting them to change their behaviour. But the patient will come out and say, did the doctor, did the doctor tell you off? No, they just wanted to know why I did it, wanted to know all my cognitions and all my feelings about this activity that I refused to change. It was a really interesting conversation, and bit by bit you get them to change. So it's a bit like children, isn't it? You can either say, stop hitting little Johnny, or you say, why are you hitting little Johnny?
I was wondering as well, with these conversations we're having today around these notions of risk, of discipline, of power, and like not to open Pandora's box too much, but we're seeing like the rise of authoritarianism, and doctors are potentially have this control position, social credits, all of these things. Have you noticed any change in your relationship with patients as things change in the world on a macro level? And have you thought about the power of a doctor in that concept in relation to politics?
That's a big question, and I don't know that it's translated to my little patch in Battersea in London, particularly, which I think sort of has the same politics it has had. So I don't think we've, it's not somewhere where Nigel Farage is going to gain much ground. I mean, I think I definitely see it in terms of people struggling financially and the kind of inevitable repercussions of that brings. But it hasn't changed particularly for me. But great question, James. I'm going to go and think about that.
Yeah, it came out of the blue there. So yeah, I'm admittedly, it's probably a bit of a big one for it's probably a podcast in itself. But just thinking again, you're seeing a lot of fear in the world at the moment with the rise of more authoritarian ways of being, and and of course doctors could be administrators of the state in that sense. It's interesting. I was just wondered if you had experienced any change in the way that people react to you. I guess it's also quite different in the UK currently probably than it is in other parts of the world, but I was just interested to see if you'd had any kind of fear or changing relationships as a result of the sort of the macro changes politically that we're seeing around the world.
I haven't seen anything in relationship to recent macro changes. I've seen definitely a loss of trust after COVID, and
yeah, same topic really.
More on the micro level, I work hard to regain the trust, but the micro level is definitely linked to meso and macro levels, and I stay away from macro levels and big concepts.
Any thoughts on that rather large topic, David?
No.
No comment on this one. No, I think it'd be very interesting to talk about disinformation at some point as well, and the effects on how that's eroding trust in the medical profession as well. But for today, Jens, Ru, do you have any final questions for David? Or David, do you indeed have any final questions for any of us?
My question for David as a Foucault reader is, where do you see the role of human agency in changing things? Is this too much of a macro perspective, and we are just part in the social life of methods and spokes in a wheel? And I wouldn't say it's so negative, because I don't mean it negative. For me, it's analyzing the streams and social movements I'm part of.
Yeah, I've written a paper about agency and the rise of agency and the concept of agency, that people can act independently, autonomous agents and so on. And it's a very recent phenomenon that's happened over the last 50 years. So we're still in that phase of actually, we're creating, we're manufacturing, we're constructing people, giving them agency and reflexivity and subjectivity. There's a lot of things which are getting stuck inside of these sort of so-called biological beings, that we're changing them and we're changing ourselves at the same time.
That's definitely the subject of a different podcast. That sounds fascinating, David.
Ru, any final thoughts from you?
No, thank you very much for hosting, James, and thank you so much for being part of this, David.
David, I just would like to ask finally, though, if people wanted to find out a bit more about your own work and your own research, is there a good place, or they just search your name and they'll bring up a selection of fine papers, or is there anything you would like to highlight?
Yeah, because I've got some sort of slightly boring medical ones sort of mixed in there. So yeah, I guess I'm on what's it called, academia. .uk,
oh yes,
whatever it is. Yeah, I'm on that website, and a few websites. Also got via King's. You can go in and you find there's a list of my publications and things. But yeah, but it's the ones we discussed today is this one I did recently about the invention of the social life of risk probabilities and how that's taken over medicine. There's one I've written about agency called Patients, Agency and something, a short history. which and other things I've done which all have a bearing on this. I suppose I tend to sort of jump around doing little studies here and there, and there must be a big picture there, but it's well beyond me.
Well, I would, if anyone's listening, I would just say give David Armstrong a quick Google or go to academia.edu, and I'm sure you'll find some great papers there to continue your kind of research in this topic. David Armstrong, thank you so much for joining us today. It was a real pleasure to have you on, and thanks for answering some of these questions. Jens and Ru, always a pleasure to have you on the podcast. Thank you all for your time, and we'll see you next time.
Oh, thank you.
Yeah,
Thank you so much.
Bye-bye.
Thank you, James. Thank you, David.
Thank you, David.